So if we can kind of go back a little bit, what they did in the Women's Health Initiative was they took, and this is from Dr. Kessel, how he used to explain it to us. There were two groups of women that they looked at. So there was group 1 had like 16,000 women.
Yep.
And then group 2 had 10,000 women. And group 1 was those with a uterus. Okay. You still had your uterus.
Okay.
Group 2, you didn't have your uterus. So
Okay.
it surgically removed, right?
Okay.
And so the group with a uterus, they gave conjugated equine estrogen to, and medroxyprogesterone acetate.
Yes.
So it was an estrogen and a progesterone. So you needed the progesterone if you have a uterus to protect that lining of the uterus. Now in group 2, if you don't have a uterus, you don't need progesterone. So they only gave them estrogen.
Okay.
There's a couple of problems, as I understand how Dr. Kessel used to kind of educate us on this. Number 1 was the age of the women that they studied.
This is a huge problem. First of all, the groups, you're absolutely correct, and they had different outcomes.
Yes.
But the problem was the population studied were women that were average age 63. So
Way past menopause, right?
They were
Yeah.
more than 10 years past menopause and didn't have symptoms.
So they're asymptomatic women.
So 63-year-old with no symptoms, and that was an entry criteria, not having symptoms.
Okay.
But then what we're seeing in the office is a 50-year-old with symptoms all over the place.
Yes.
So what we saw in the office is not what was studied in the Women's Health Initiative.
Got it.
And then the second problem is with the types of progesterone and estrogen they used, right? Mm-hmm. So as far as the estrogen, and this is so, it's complicated, but they gave them conjugated equine estrogen, which is from pregnant mares, right?
Pregnant horse urine.
Pregnant horse urine. That's
Okay.
how we got our estrogen.
Okay.
So they gave them conjugated equine estrogen, and they gave them a medroxyprogesterone acetate. So now we don't use those types of hormones. We kind of steered away from that because they were thought to, after this study, they were thought to kind of increase inflammation and then kind of increase the risk for cardiovascular disease because they just act differently than what we use now. So
Okay.
now we use estradiol and we use like a micronized progesterone.
So basically, the medicines have gotten better.
Yeah,
Yes.
they now duplicate what your body would have made.
Okay.
So that was problem number 2 is we don't use those things now.
And correct me if I'm wrong, but I mean, I would assume your breast cancer rates in the 63 plus crowd
Yes.
is higher.
Yes,
It's
At
going to be
baseline.
higher at baseline than your people who are going through the perimenopause
yes.
phase, which is probably, like you said, maybe late 40s, mid 40s to mid 50s, right?
Right.
That are having the greatest symptoms,
Right.
right?
And
So you're essentially treating people in the menopause phase, the 63-year-olds,
yes,
without symptoms,
Yes.
right.
with hormones, right?
Yes.
It's like it kind of
It's like giving your mom
it's like doing a
hormones
hormone.
that she doesn't really
it doesn't really need.
need.
Yeah, it's like doing hip replacements on people without hip pain, and then
Correct.
finding out that these people have more complications.
Right.
kind of,
Right.
right?
Yeah,
Yeah.
so I okay, that's
So that's
interesting.
why there is all this
Got it.
hullabaloo with this study because it was terminated prematurely because of bad statistics and bad media coverage.
And probably the wrong patient population
wrong
choice.
patients.
Yes.
And then
Yes.
with a different type of hormone.
You know, if
So-
you take someone in their early 50s, their benefits are higher and their risks are lower.
lower.
So
Yes.
you're right. When you're 63, your baseline risk for breast cancer is going to be higher already.
Yep.
Yeah, exactly.
So since that study, and you said that the sort of the hormone replacement therapy seems to have gone
Way down.